one of the first things I like to point out is, well, why do I drive around doing all these? Because most surgeons don't want anything to do with it. That ought to tell you everything you need to know. They got plenty of good surgeons over at Conway Hospital. The reason I go over there is because Dr. Mills couldn't get any of the other ones to do it. Dr. Sasser used to do it. I know Paul Sasser very well.
Mm-hmm. I've seen him.
Have you seen Paul?
Yes.
He used to do it. And once he sold his practice and is now employed by the hospital, he just doesn't have the desire to do it. And that ought to tell you a little bit about this. So I do this total for 6 guys at 3 different hospitals. Now this morning, I've already been talking to Dr. Mills and Dr. Shawn. I've been texting them because this morning I started going through all my charts and looking. I saw yours, saw that you had an MRI, went and pulled up everything on joints, which is the OrthoSC's PACS system, so I can look at all the x-rays. Looking at the MRI is very important to me from a blood vessel standpoint, not from a spine standpoint. And the first thing I saw was that you looked like you'd had an EVAR or PVAR. Where they had the lines, I was concerned that what I was looking at as L4, L5, they were calling that L5S1, and if that's the case, you would have something called transitional anatomy. But good news, you don't. Now, I used to do vascular surgery. I used to put these stents in myself. How long have you had that done?
It was November 5th.
Of 24?
Yes.
Okay. Who did it?
Dr. Veeraswamy.
Veeraswamy did it. Down where?
Down at MUSC.
At MUSC. And did he do incisions in your groin?
Yes, he went on both sides.
Yeah, but did he do big incisions, or did he get little poke holes?
Poke holes.
Okay.
They were poke holes.
Yeah,
They said that the tube that he used was about like that.
Yeah. Well, when they do it with the small incisions, we call it a PVAR. And when we do it through bigger groin incisions and cut down on the arteries, we call it an EVAR. There's a good reason to do one or the other, and I've been involved in many of them. At Grand Strand, and we do not, my former partner, Dr. Borowitz, is a vascular surgeon. At Grand Strand, we don't do any redo EVARs, those that have been done before and have failed. And we don't do any that go above the renal arteries. And once they get to that, that's when we get them down to MUSC, because they got all kind of little gizmos and whiz bangs, and they've got a big medical center with a whole lot of people in it.
Mm-hmm.
And so they just typically don't do that.
Dr. Sasser was the one that recommended
Yes,
Veeraswamy.
I would imagine Paul is the one that sent you down there. Now, you still smoking?
Unfortunately,
Have
yes.
you lost your effing mind, dude?
I know.
We just met, and I'm going to talk to you like that. I mean, you're absolutely doing everything you can to put gas on the fire, man. I mean, to be able to have that, what you have is alone amazing, because in the olden days, and I mean in olden days like 10, 15 years ago, you would have a big incision in your abdomen from stem to stern and a big Y-shaped graft put in, and that's called an aorta bifemoral bypass graft. And if you let this get all screwed up because you keep smoking, you're going to end up having to have some revision, and it may be nothing more than it being able to take one limb and go across your groin over to the other limb and give you maybe about 5 years before you end up getting in a situation where you lose your leg. And there you go. That's the facts. You can call Dr. Veeraswamy down there and tell him what I said, and he would say, good for him. Glad he told you that. He would have probably also told me that he told you that.
Yeah.
Yeah.
I don't smoke near as much as I used to.
Well, we need to put it into it like, well, on your way home. On your way home, stop by the nearest trash can, put them in there. If you got any ashtrays in the house, empty them, get rid of them. Any area you like to smoke in, get her to put a potted plant there. The reason I say that is I come from a big family of smokers. My dad smoked till the day he died. He was 84 years old. And he was a lucky man because, and I'm sure the smoking got to his heart sooner or later. But, he cheated death, and that's no reason to say it's okay. It's a universal bad. I love tobacco. You could fill a mattress with it and not sleep on it. I mean, I've chewed dips. I love a cigar, a big nice bowl of pipe, but I don't do it because it's bad for you. And I'm getting too old for me to have stuff, and I don't want to have my legs cut off, and I don't want to have to go through all these miserable operations. So, that's where I'm gonna go with that. Now, have you had any other operation in your abdomen?
No.
Nothing
The
but
only
the-
thing I
but
had
the
was,
endovascular treatment.
I had a
Vasectomy, but that's,
Vasectomy? Okay,
yeah.
so I'm gonna want Dr. Ramaswamy at MUSC, I'm gonna want his op note.
Okay,
And he did it less than a year ago, so we ought to easily be able to get it.
I got it.
Because I just wanna see if he did an EVAR and PVAR, and if he had to, what we could call snorkel it or anything like that.
He's got to go every 6 months because they're pretty much sure he's going to have that big incision surgery because these stents didn't do very well.
is what
And
they're
he's still
saying.
smoking. I mean,
Well, from the first,
Yeah,
from the
from right
day
when it-
after, they still had a hard time
Because he
finding
was still smoking the
pulses.
day after. I mean, if you haven't picked up on it, I'm a little bit of a hard ass, and I haven't even started talking about this. We're just talking about what you had done before, but I'm setting the table here because this is a big deal.
Mm-hmm.
One of the things that I can do when I do this is knock off the blood supply to one of these stents, depending on what you've had done. Now, if you've had what looks like you've had done on the MRI, you've had an EVAR or PVAR, which is we go in one, and most of the surgeons I know go on the right side and put the bigger graft, and it has a little bifurcation to it or a split, but it goes all the way down, and then they come down the left and they put the other piece on to add to it, and that's the thing that makes it so that you don't have to have the big surgery. Now, when I do the A-lift, I'm actually going in between where those two grafts are, and I'm going to be pulling all that apart. Okay, and that's why I'm concerned about it, and that's why it affects me very much so. The nice thing about what we got going for us is that unlike the old days, you didn't have to have a big abdominal incision. If you'd had to have that, I probably would have already said no. Probably would have even told Dr. Mills not to even send you to me. But having the stents on the inside, in addition to having a quicker recovery, is a miracle because it also means that we haven't violated your abdominal wall and it violated your biggest blood vessels. But, look at that.
He's on top of it.
Yeah, it's on top of it. Okay, here's some. Aortic iliac occlusive disease, bilateral common femoral artery percutaneous access. Aortic endostent, infrarenal location, 11/29, placement of bilateral iliac stents, percutaneous mechanical thrombectomy. So he has done exactly
Here.
he is doing it by the book, man. I opted not to pursue percutaneous manual thrombectomy more aggressively with large catheter. I was concerned about embolization. That was absolute. Now, I just gotta find in here if you went above your renals or not. I don't think so.
He didn't.
I think it's below.
Yeah,
Yeah.
he left a couple inches, he said,
That's good.
just in case he was, if we gotta go in and
Well,
replace
if you have to go
it.
back in, that's called a cuff, and he'll need a cuff if he's gonna have to do it open. Okay, well, that's good. This was very helpful. And this guy, you got some good work done. Yeah. Let's see which company. Was it Gore-Tex? Yeah, Vibon. Put Vibon's in there. Awesome. So Vibon stents are Gore-Tex, which they don't last as long as some of the other type stents that are used, but they're easier to put in and they have less of a issue. But, Dr. Ramaswamy can tell you all the details about that more than I can. But be that as it may, now we've set the table for talking about the A-lift. Okay. So I've ragged on you about smoking. I've talked to you about what you had done. The next thing is talking about the ALIF. So ALIF stands for anterior lumbar interbody fusion. Okay, and the actual definition is right in what I just said. Anterior means we're coming from the front. Lumbar, we're working on the lumbar spine. Interbody, we're working between the vertebral bodies. And fusion, we're wanting these two vertebral bodies to become one, to fuse together. This is it. This is L5S1. Okay, so you know your spine goes from the base of your skull all the way down to your tail, and you got the cervical spine. You've got the thoracic spine, which is associated with ribs, and then the green is the lumbar spine, and the orange is the sacrum. This is where the majority of people get problems, and this is why this is the most common level done. This can be the trickiest to do from my standpoint. This is actually what one looks like. Now, Dr. Alsey's will look a little bit different. But this is one that Dr. Massey, who's one of his partners at Spaced at Grand Strand, uses, and this is called AlphaTech. Dr. Alsey usually uses a company called Globus, and I know all of those guys real well. As a matter of fact, I'm going to be with them. I'll probably be with them tomorrow. So the whole idea of your operation is actually pretty simple. You see these little orange things coming out right here? Those are nerve roots. And as your spinal cord terminates, it goes in and it makes these nerve roots. And right here, you have collapse of this disc, and it was pretty rough, man. And you have collapse of this disc, and it's slipped, or what we call spondylolisthesis. And what that does is it makes this hole on either side smaller. Mm-hmm. And because the hole is smaller, it's compressing on those nerves. That's what people mean when they say pinched nerve. So do you have symptoms on both sides or one side? On the outsides. The other thing I have to be careful of is that we're not confusing discogenic pain, or pain from your spine, with peripheral vascular disease pain.
Right. That's why Dr. Mills had me go to Sasser and do all that, and that's why we went to Veeraswamy, because he wanted to eliminate.
That's right. So you had that done almost a year. We're almost at a year since Veeraswamy did that. Have you had any studies done since then? Any ultrasound studies to check the flow in your arteries?
Yes.
You have. Where was that done? Was that done at Veeraswamy, or did
that was
Sasser
Veeraswamy that did that?
Veeraswamy did that. So
because we went. Here's after I had the stents put in, right? They were supposed to get a CT scan with dye here, mm-hmm. right? No one could find anything. So I went to Sasser and I said, I need to get, this because of, what they did. So he set that up for me, right? We go in there and he looks at me and he goes, you walked in here? I said, yeah.
Wait. Okay. This is when?
When was that? February?
This is after you had the
After I had the stents.
Okay.
He goes, I can't do nothing.
When he saw the CT, it looked like there was no flow at all.
Right.
But
now,
this is after you had Veeraswamy do this.
Yes.
Did he send you back to him?
We have seen him since.
I've seen Veeraswamy since. I've been there twice since.
Okay. When was the last time you saw it?
That was just what, a month, 2 months ago.
July.
Yeah, July.
July. Okay. And I'm sure has he done ultrasound study?
Ultrasounds, yes. They say that my flow is weak, but I do have flow.
Okay.
He thinks that the CT, there's some fluke thing that happened there because it can't be that bad.
Was the CT at MUSC too?
No, that was at CMC.
Conway. All right.
Yep.
So I need a CT from Conway, and I need Dr. Veeraswamy's ultrasound where he'll have ABI. So it'll say arterial duplex with ABIs. And that's got to be on file. And then the CT at Conway.
We might want to get another CT actually too, to be honest, because when I had that CT done, I was telling her my first one, I felt the warmth from the CT scan through my whole entire body. I mean, I felt it in my feet, here, my head.
That's normal from the IV injection.
Right, while you're going through the machine.
Yeah, no, it's just from the injection. It makes you feel, and you feel like you got to pee.
I didn't
I've
feel like I
had
the tea.
one before, man.
But I mean, I felt the warmth. I could feel
Yeah.
the warmth from the stuff. Now, the last time I had it, the only place I felt any warmth was right over here.
All right. When you walk, can you walk as far as you want to?
Nope.
How far can you walk before you start getting Charlie horses in your leg?
I haven't had Charlie horses in a long time.
Before the surgery.
Since
before
before, yeah.
Right, but
I used to get them real bad in both legs.
So what makes you stop?
The pain. What actually
The back
happen,
pain or the
it
pain
starts. The pain starts right here,
Yeah.
and it'll just start radiant down.
All right.
It goes into my
Okay,
feet.
so-
The easiest way I can explain it is like the tingling from when your foot falls asleep, but I don't have the pins and
All right,
needles.
so that's due to your disc. Okay, so you see what I'm trying to do is I'm trying to sort out
Just,
claudication pain, which is pain from lack of blood flow, from discogenic pain, because we're not going to do a damn thing about vascular pain by doing your back operation. So let me get back to this. Now we're getting better information. So this is the disc that you have that's most diseased, and this is the one he wants to get. The reason he wants to do an A-lift, and he has other choices besides an A-lift. He has one other choice. But the problem is, getting in a big implant like this gives the best results. It gives the best results so that the pressure is taken off from both sides, and he doesn't really have to pick a side. Okay, and so you have a better chance of getting relief of this thing going down both sides. He can come from behind, and that's called a T-lift. But like I said, it's a much smaller implant, and it usually favors one side over the other. The other choice is to come in from the side, called an X-lift. And the problem with that is, as you can see in this diagram, he can't come right here
Right.
because the hip bone is in the way, so he can't really do this. So his choice for this level, to be able to lift this space up and to get these two bones to grow together, is an A-lift or a T-lift. The reason you're here to see me, and the reason I've been sitting here talking to you for as long as I have, is because I'm the access guy, and I take responsibility for getting everything set up for
Right.
Dr. Mills. Sometimes it'll take me an hour and a half and 2 hours to get the access, and then I call Dr. Mills, and he comes in and knocks in an implant in about 10 minutes. You know, and sometimes I go, wait a minute, how come I don't get where's my big money?
right.
But this is something, I've been doing this for going on 12 years. It is something I've spent a lot of time and hard work learning how to do. And it's something that I take a lot of pride in doing, but it's also very stressful. And I'm just getting started talking about that. So, what is the big deal? Well, in order to get from here to here, I have to go around all of that. I don't go through it, I go around it. So I'm not going inside your abdomen, I'm going around it and moving the inside layer and moving it over. So, Christiane gets tired of hearing this, but think of your torso as a bag within a bag. Imagine a burlap sack with a Hefty bag put inside it. And we fill up that Hefty bag with balloons and liquid. Well, my job is to make an incision in the front in the burlap without puncturing the Hefty bag. And then taking the Hefty bag and everything that's inside of it and pulling that over to the right and holding it over to the right. And I also have to take the urine tube, or the tube that drains urine from the kidney down to the bladder, the left one, and pull it all the way over to the right tube. So you see that right there, and there's another one there. So where you had your stent is right here. It's the aorta and both of the femoral arteries, okay? Do you see this white blotch?
Yeah.
That's L5S1.
Oh, okay.
That's actually it. They're showing the L5S1 in this diagram to show you the relationship of it to the rest of the vessels. So I'm going around all that and going in here in between some of the largest blood vessels in your body. And you also have stents inside of that. And I'm going to come to that in a minute. Usually, with most patients, the thing I got to worry the most about is this big blue thing here. This is the left common iliac vein. As you see, it parallels the artery, but it's a little bit to the middle of it because your vena cava is to the right of the aorta. So this lays more in front of the disc, so it's more likely to be injured. Now, you know, you've had all this artery stuff, and you hear about how terrible it is when our arteries injured and whatnot. Well, that ain't usually my problem, because arteries are thick and they can be clamped, and they can have patches and grafts put in them. Veins don't tolerate that very well. Veins are about as thick as this piece of tissue paper, and they're about as big around as anywhere from your little finger to your thumb. Even if you put a little hole in the vein, even though the pressure isn't as high as the arteries, the flow rate is tremendous. It's carrying all the blood back from your left leg. And if I make just a little injury to that, or if it has a little tear in it, it can bleed like the dickens before I get it stopped. And it happens. It happened with Mills. It's happened with Alsey. It's happened with Cook. It's happened with Massey. I've had it happen with pretty much every surgeon that I work with. But everybody that I've ever done it on has actually gone home. You know, I've lost a few years off of my lifespan, however. But these two little veins, these two little blood vessels you see in the front, I have to find those and tie those off if they're there too. Those are called middle sacral vessels. You can do just fine without them. The other thing I have to be concerned about is if you had a bunch of inflammatory reaction to the arteries around where the stents are put in, then it can make it so that things are stuck together. And if this thing is stuck, it's going to be very hard for me to move. Now, to be honest with you, looking at your MRI, I look like I've got a pretty good bit of room between the arteries and the vena and the iliac veins. It's just a matter of making sure that I don't knock off the blood supply. So these stents are made out of a material called Viabond, which is, they have a metallic layer and they have an inner layer of something called Gore-Tex. And I don't think it's likely to happen, and everybody hears this, even if they're not a smoker that's had this operation done. I have to put these paddles in and pull that apart and use it to protect. Because Dr. Mills, one of the first things he's going to do when I give him access and he's getting ready to do it, one of the two first instruments he's going to put in his hand is going to be a hammer and a chisel. Literally. Now, we don't call them that. We call it a mallet and a cob, and it sounds very surgical. But if I showed you pictures of them, you'd understand what I'm talking about. It's a hammer and a chisel. Because he has to remove the middle part of this disc so that he can get to where these two discs are able, these two bones are able to be separated. And then what he'll do is he'll do what's called disc prep, where he'll remove the disc. He's got to have bone and bone without disc on it. Then he's going to use these different sizers that he's going to put in with a hammer one at a time, called trials, and that'll help him decide what size implant. We have the reps for the company are there, and they have all these different, and I can almost assure you that when Veeraswamy did your procedure, he had reps with him that are experts in that equipment. Well, the same thing in this kind of operation. We have people from the company that are experts and know where everything is and what thing can go with what thing. Mills will try to see if he can get as big of an implant as he safely can, because that's going to take the pressure off your nerve roots. In addition, if you see, this thing has like a rectangular hole in the middle of it. The system that Mills uses does too, but it's a little different, and they put bone graft material in, because ultimately what they want is they want this bone and this bone to become one. They want this implant to keep them apart, and then this bone and this bone to become one, because if they become one can't slide over to the other, one can't collapse anymore.
Right.
So that's the whole point of the operation. It's just a matter of getting it done. So what can go wrong? Well, first thing, I always start from the front and go to the back, all right? So your wound, okay? If you're still smoking when you have this procedure, I can almost guarantee you Sean's going to be calling me saying the wound looks bad. And they need me to look at you, because that nicotine and that smoking affects everything, even the tiny, tiny little blood vessels that come and bring blood to the edge of a new wound. And it is a routine in a smoker. And it's not just with spine surgery. When I do hernia operations or abdominal colon operations or whatever, and every one of those patients got to hear me right. You know why I'm ragging like this? Because I've been doing this a long time and I understand the significance of it. I mean, I will tell you, there are plenty of spine surgeons that wouldn't even consider doing your back operation if you're still smoking.
Right.
You know, most of them today will get they'll get a blood test on you to make sure that not only are you not smoking, but you ain't been smoking in a while. So, you know, because we understand how much it affects surgical outcome. We understand how much it affects even the littlest things like your abdominal wound. Now, my incision will be to the left and straight up and down. The usual next question I get is, how big? Well, as big as I need it to be. I won't make it any bigger than necessary, but I'll make it as big as I need it to be. I'm going to measure you here, but you're not an overweight guy. Most of the patients we do are overweight. And they're overweight because they're miserable, they can't exercise, and they eat because other than smoking, the thing that gives people a little pleasure is eating. And so I have to talk to most patients about weight loss. I don't really have to do that with you.
No, I'm not.
You know,
I got a little belly, but not much.
But and once you quit smoking, it's hard not to gain weight because that's one of the first things that happens. But wound infection, disruption of the wound, slow wound healing. You can get a hernia where I made the incision. Okay, it's actually very unusual. Now, if you were ultimately to have an aorta bifemoral bypass graft like Ramaswamy's telling you, there's a high rate of you getting a ventral hernia after that. We fix a lot of hernias in people that have had to have actual aortic surgery, which is another advantage of having the stents put in. There's risk of you developing an abscess back in this area. When I go in and move everything out of the way, it creates a space where there was none. And that space after surgery is going to fill up with blood and fluid called seroma fluid, and your body will gradually absorb it. If that stuff gets infected, it can cause a bad abscess, and we'd have to stick it with a catheter using CAT scan guidance, and then it's going to mean that there's a high chance that new implant that Dr. Mills put in is going to get infected. And it can mean as much as you having to have lifelong antibiotics after that. Because once one of these gets infected, we can't just take it out. You know, if somebody gets an infected total knee replacement or total hip replacement, they can remove that hardware. They put antibiotic stuff in there and they wait.
This you can't. Right.
This you're stuck. You can't. You know, this is a one-shot Charlie. This is not something we're going to get multiple opportunities to do. There's risk of injuring the urinary tract. You know, one of the things I do is I'm going in, and by the way, these are the first two instruments I use. And once I make my incision and I start going in, I'm looking for the left ureter, because that ureter should be coming and I'm going to pull it over to the right. And the next thing I should be looking at is all those big blood vessels. I use a retractor system. It's called the SynFrame, and it retails for about 250 grand. Conway's got two of them for me. I got two of them for me at Grand Strand as well. I've tried different retractor systems. This is the one that I like the most and works the best. A retractor system is a system of paddles and blades that pulls things apart and holds things apart. We surgeons, when we're working, we want to be able to get to the thing we want to without something we don't want to getting in the way. And we certainly have to do that with ALIFs, especially since I'm going to be setting up this to try to protect a vein that Dr. Mills is going to be chiseling literally about 3 or 4 millimeters away. And me getting that retractor system is very important. It'll be, when you're asleep, it'll be bolted to either side of the table. It'll be a ring that I put in, attached to those rods over where your incision is. And then I put in the different paddles. I have a lot of range of different widths and sizes that I use to do this. There's risk of blood vessel injury. I think I've covered that. Mm-hmm. The other thing that really concerns me is if you have, and that's why I want to look at your CT and all that stuff, because if you have clot inside those iliac arteries, it's not safe to do this operation. Because what will end up happening is I'm going to end up taking those retractor blades and pulling them apart. And if I have to pull those arteries apart and there's clot in there, I can make the clot dislodge and go down and call it an embolus. Exactly what Dr. Ramaswamy was saying why he didn't do the big thrombectomy, because he was worried about showering. We call it showering clot. And that can cause you to lose your toes or even lose your foot or lose your leg. And that's what, if I see fresh clot on the CT scan, and I'm kind of concerned because what you're saying, because I know Paul very well, the way he was reacting, it may not be safe to do this procedure. it may be something that we have to do something different with.
That's why I'm wondering if we should do it, if we can get another CT then.
Well, I mean,
Because I don't know if I trust that first one.
the,
I really
The
don't.
late-
and that was done at Conway?
Yes.
Okay. What you need is something called a CTA, or CT angiogram. All right, this is the one. Oh, look at you.
And then this is the office note from July.
Okay, I wonder if Dr. Mencken read this. Dr. Kramer wrote this. Dr. Kramer's very good. Let's see. Aorta, infrarenal aortic stent and kissing bilateral common iliac stents are occluded. There was previous infrarenal abdominal aortic occlusion on 8/5/24 without stents present at that time. So your stents are clogged. Renal arteries, no significant stenosis. Yeah, I don't know that we. I think I see why Dr. Sasser was a little concerned. And you haven't noticed much difference? That means you develop collaterals. So when you have a blockage, your body finds a way around it. And one of the things that surprises vascular patients is when you're starting to have problems like Charlie horses, we tell you, well, go to the point where you get to Charlie horses and keep walking. Because we want you to get the muscle being starved of oxygen, because that encourages more blood vessels to grow. I had an injury to my thigh many years ago in my shop. I have to admit it was an arrow. I'm a bow hunter, and I had a broadhead mounted on this shaft, and I was sharpening it on the grinder, and I turned it the wrong way and flung it into my leg. And it took out the end of my profunda artery, which is this artery out here, not the end of the world. I only lost a piece of it. We were able to get it tied off, and blood flow has found its way around it since then. That's been many, many years ago. But the concern I have is that if you've got occlusion of that, and then I get in there and pull my retractors on that stent, and I squish clot goes down to your foot. Now we've got somebody who we've done an ALIF on, we've put hardware in, and now you've got a whole nother problem for which you're going to have to go down to MUSC.
So there's clots in where the stents are.
That's exactly what it says.
So how do we get rid of that? How does that get cleared out?
Well, I don't know that it's going to. He can try to declot it. Dr. Ramaswamy can try to declot it, they go up there with balloons and try to pull clot, or they try to do something called thrombectomy with a suction catheter. But by this point, it's probably organized, and organized means that it's hard and it's stuck. It's kind of like made a scar. So, I mean, from a vascular standpoint, from just keeping them safe, I feel confident that I can do that. Your body habitus, I don't think that would be hard. What I'm really concerned about is us create a worse vascular problem doing this operation. You got an appointment to follow up with Ramaswamy?
It's January 25th. He wants him back there.
I'd say try to get in, see him sooner so you can make a decision about this. If I'll put it to you this from my standpoint, if Dr. Mills and Dr. Ramaswamy know about this and they say it's, I mean, you've got a strong indication to have an ALIF done. If you didn't have this vascular problem, I'd already be done talking to you. I'd already be sending Sean a message saying let's sign him up. But with this, I'm worried about the biggest thing a doctor must do is make sure that we don't make things worse.
Right.
That's more important than making anything better.
Mm-hmm.
And that's the spirit in which I say this. And I've taken the time to really kind of, has it at least helped you understand what all the ramifications are?
Yes.
And you need to ask questions. Ask all the questions. Well, how old are you now?
52.
Yeah, man. I mean, you way too young for this, man. You got a lot of life to live, and you've already had one shot, and you'll have another shot with the aorta bifium. But that's a big operation. Once you have that operation, I don't think an ALIF is going to be possible. But once you've had a big incision, And they can do it one of two ways. They can go through the abdomen, which is what most surgeons do, or they can make a flank incision and do the same kind of approach I would do and come behind all that, which is a little bit more technically challenging for them. But I would defer to him as
Yeah,
to that
Varys Sloan
decision.
said if he was gonna
And-
do it, he would
And
do a big one
and
and
these
pull
and,
everything
and
out.
this CT scan is fine. You don't need another CT scan. He gave us the answer we need. It's telling us where's the
Back.
there you go.
I know she had a hard time getting into my vein.
Oh, but they got one in there because they've obviously got the contrast in. So it says. Aorta, infrarenal aortic stent and kissing bilateral common iliac artery stents are occluded. There was a previous infrarenal or abdominal aortic occlusion on 8/5/24 without stents, so he's saying you've got it again. No significant stenosis. Wonder how much if he says you got runoff. Let's see. Here we go. Impression. Occluded aortic and bilateral common iliac stents. Dude, you gotta have a lot of collaterals or you'd already be worried at the point of losing your legs. No significant femoral, popliteal, or runoff disease. There you go. You heard me use that term runoff. So what he's saying is that your grafts are occluded, you've got collateral circulation that's allowing blood to get to your feet. But that could last for the rest of your life, or it may get worse as time goes on. Everything hinges on you. I mean, I'm not kidding you. Fuck all that Nicorette patches and all that stuff. You're looking at being a guy sitting in a wheelchair the rest of your life. And you got a lot more life to live. Because the only thing you're hanging on by is collateral circulation being able to get down to your legs. You knock that off, your legs are done. And there's no getting it back. And that's if I haven't accomplished anything else from this standpoint, I hope I've really drilled it into you. That's him. Has anybody ever talked to you this hard about it?
Not like that, no.
Well, I'm
But I
telling
want to
you.
say thank you for that.
I'm telling you. I mean, I honestly really care about you, and I want to make sure that you don't get worse and you get better. What Dr. Ramaswamy was telling you, now, forgive me, and don't tell Dr. Ramaswamy not to get mad at me because I don't know him, and I don't know exactly what he said when he was there or not or anything, but I know vascular surgery, I know vascular surgeons, and I know how they think, you know. And what he's saying is you might have to go back means that if you get to where you're getting ischemic problems down here before, if you develop a collaterals and you quit smoking, you may be able to live the rest of your life and be okay even though your iliacs are occluded. But your iliacs are occluded, they're done. So you got clot in here and in both of these big arteries right here. So the only way the blood is getting to your legs is it's found in another way around. You see all these things right here?
Mm-hmm.
There you get these big collateral vessels that grow and they're able to nourish your feet. But if you quit smoking, you're going to knock them off. And if you knock them off, then you're going to have no blood flow to your legs. And I think that trumps our ALIF. So I would recommend that you go down and see Dr. Ramaswamy as soon as you can and not wait for that appointment. And literally tell him, you know, this crazy general surgeon that saw me for the approach and read me the riot act, and he wants to know if it's even a good idea to do an ALIF. You know, I mean, Dr. Mills can do the T-lift from behind with the pedicle screws if he so chooses, and that will at least elevate this and relieve your symptoms. And if he does it that way, there's no danger of me showering clot from my approach.
Mm-hmm.
And I could do it and not shower clot down there. But there's only one way we're gonna know that.
Yeah, by doing it.
Right. And
But the
then when
less risk is to go in through the back.
the risk of going through the back, the biggest risk of going through the back is not getting as good a relief.
Right. I just mean it's less risky.
This is ideal. This, and study after study, this wasn't in existence when I was a resident doctor. This came into being afterward. And that's when I started doing this, is when I started seeing more of the spine surgeons doing this operation. And now, they love the results from this so much, they got me hopping, you know. I go from one hospital to the next sometimes, and you know, and the reason they can do it is because they got a guy that's willing to do it. And I'm not God's gift to anything. I'm just a dumb old general surgeon. But these ortho spine guys, man, they're not comfortable going through the abdomen or working around the blood vessels. So what they do is they ask me to do that for them. And that's why I'm called an approach or an access surgeon. If I was in a big city like Atlanta or Charlotte or New York or Chicago, I could probably just do this for a living and nothing else. You know, and I know a guy out in Denver who does this at 20-something facilities. You know, just a general surgeon. So it is something that is a real deal and a big deal. But I think we got other fish to fry with you. And if I haven't done any good at all here, that smoker's got to just up and stop the hard way. Cold turkey, you know. I'm looking at my life without being in a wheelchair. You don't want that, dude.
No.
And the other thing is that pain back here can also be from you'll look up something called Laurentius syndrome.
That's what he has.
Yeah, Laurentius syndrome is no pulses here, impotence, and then pain back in the gluteal area. Right. So, you know, with you having that, the Laurentius syndrome, I'm not sure that an ALIF is a safe thing to do on you. And it makes it even more important that you got up in that smoke. Don't throw them out on the side of the road. Just go in the way out of the parking lot, put them in a trash can. All right. Now, if the powers that be go round and round and they say an ALIF is the best thing for him, we should be able to do it. Dr. Ramaswamy says as long as he doesn't have occlusion, I'm not too worried about it. And I'll be happy to see you again, and we'll talk again, and we'll revisit it. Okay? All right. I know I'm not telling you what you wanted to hear, but
We just want him out of pain. It's been so long.
I understand, but you were having one kind of pain. Now you're having another kind of pain.
I had both on top of each other.
Yeah, man. That's, you know.
I was getting the cramps. I mean, they went from my hips
I mean,
to
I've
my
looked at your
toes.
MRI. You don't have to convince me your disc is bad. It is bad.
Is there anything you can do in the meantime for any kind of relief?
Well, I mean, what has Dr. Mills tried? Usually before they...
None of the injections worked.
Yeah, I was going to ask if you had any kind of injection. And what worries me is that if the injections aren't working, is it because the pain is vascular and not spinal in the first place? See what I'm saying? So I don't have an answer for you. I really don't. But, you know, this is something that is very simple in terms of the explanation of it. But it's hard to get a good solution and a good answer.
Mhm.
All right?
Right.
But once again, you see how long I've been talking to you. I'm an independent doctor, so I don't work for a hospital or anything. I can take all the time I want to. This is like, when I do these procedures, this is the one chance we get to meet, so I want to make sure I go over very thoroughly what my part is. But ultimately, the decision is going to be made by three of us. By me, Dr. Mills, and Dr. Ramaswamy. So I would definitely call, make a sooner appointment to go see him. I don't think you got to worry about getting a new a CT scan. It told us what we needed to know. There's no reason to go through that again. And if they want to send you back to me, I'm happy to talk to you again. All right.
Okay.
But right now, I don't think the ALIF is the thing to do. Okay. All right. You're welcome, man. Y'all hang